Welcome to my YouTube channel MBBS Buddy. Today we are going to discuss about diabetes mellitus, introduction, classification and pathogenesis. Definition: it is a clinical syndrome which is characterized by hyperglycemia due to absolute or relative deficiency of insulin or both. That is, there may be defects in insulin secretion, insulin action or both. Etiological classification: we have type 1 diabetes, type 2 diabetes, other specific types of diabetes, and gestational diabetes mellitus. Under type 1 diabetes, we have type 1A, which is immune mediated, and type 1B, which is idiopathic. Under other specific types of diabetes, we have genetic defects of beta cell function, that is maturity onset diabetes of the young, MODY. We have genetic defects in insulin action, that is type A insulin resistance or lipoatrophic diabetes. There is diseases of exocrine pancreas like pancreatitis, pancreatectomy, etc. Then other endocrine diseases like acromegaly, Cushing syndrome, pheochromocytoma, infections like congenital rubella, cytomegalovirus, drug or toxin induced, it may be by glucocorticosteroids, then thiazides, protease inhibitors, and insulin receptor defects or insulin receptor antibodies. And at the last, other genetic syndromes like Down syndrome and Klinefelter syndrome, also Turner syndrome. Now, type 1 diabetes mellitus, it is basically absolute insulin deficiency, right? Now, type 1 is further subdivided into type 1A and type 1B. Like we discussed before, type 1A is cell-mediated autoimmune destruction of beta cells, and type 1B is idiopathic, that is, beta cell destruction occurs due to an unknown cause. It most often occurs in younger patients, but nearly 10% of the patients above the age of 30 years have this type of DM. So the age distribution is not that specific. In type 2 DM, there is variable degrees of insulin resistance, impaired insulin secretion, and also increased glucose production. So it also occurs due to several genetic and metabolic syndromes. Some children again have type 2 DM. Maturity onset diabetes in the young, that is MODY, it is an autosomal dominant inheritance, early onset of diabetes, and there is impairment of insulin secretion and lack of autoantibodies. Now let us discuss why does type 1 diabetes mellitus occur, that is the pathogenesis of type 1 DM. First we will discuss type 1A. In type 1A, this is the flow chart. First, there is a genetic susceptibility. By that we mean that genetic susceptibility to the disease must be present. About 95% of patients with type 1 DM either have HLA-DR3 and or DR4. Second step is the environmental event. In this environmental event, it initiates the process in genetically susceptible individuals. Step 3. We have insulitis. What is insulitis? Insulitis is an inflammatory response in the pancreas. There is infiltration of the islets with activated T lymphocytes. What is the fourth step? The fourth step is the activation of autoimmunity. What happens in this step? In the activation of autoimmunity, there is an alteration of the surface of the beta cell such that there is no longer recognized as self, but it is seen by the immune system as a foreign cell or non-self. Thus, the immune system attacks it. In the fifth step, we have immune attack on the beta cells. So, there is development of an immune response. Though islet cell autoantibodies and several other autoantibodies are present in most patients, they are actually not involved in the destructive process. What causes the destructive process is the activated T lymphocytes, which present in the islets release cytokines like tumor necrosis factor alpha, then interferon gamma, and interleukin 1. That destroys the beta cells. Also, CD8 plus cell induced cytotoxicity and apoptosis are also involved. This now results in an immune attack on beta cells with resultant destruction of beta cells. So when more than 90% of beta cells are destroyed, diabetes appears. So we can say that type 1A DM appears when more than 90% of beta cells of pancreas are destroyed by an autoimmune process. Trigger the transition from glucose intolerance to frank diabetes are often associated with increased insulin requirements that might occur during stress, infection, or puberty. there is something called the honeymoon phase. Here what happens, following initial development of frank DM, many patients become euglycemic without need of insulin for some time. This generally lasts for few months, after which the patient develops frank DM. So basically what happens in the honeymoon phase, there is 70% destruction of the beta cells. So until and unless there is 90% destruction, the frank DM will not occur. So this is what is honeymoon phase. Markers of immune destruction of beta cells. We have the islet cell autoantibodies against insulin, autoantibodies against GAD65, that is the glutamic acid decarboxylase, and autoantibodies to the tyrosine phosphatase IA2 and IA2 beta. One and usually more of these autoantibodies are present in 85 to 90% of individuals when fasting hyperglycemia is initially detected. In type 1 ADM, we also have strong HLA associations with linkage to the DQA and the DQB genes, and it is influenced by the DRB genes. These patients at the last are also prone to other autoimmune diseases. They can develop Graves' disease, Hashimoto's thyroiditis, Addison's disease, etc. Type 1b DM, as we discussed, it is idiopathic, the cause is unknown, it is strongly inherited, lacks immunological evidence for beta cells autoimmunity, and is also not HLA associated. So it is different from type 1a. Now let us look into the pathogenesis of type 2 DM. Type 2 DM, the main center point is the insulin resistance, right? So here we can see in this chart, this insulin resistance may occur due to any genetic factor, or it may be due to any acquired conditions like obesity, sedentary lifestyle, or aging. This insulin resistance then causes hyperinsulinemia, which further causes compensated insulin resistance and normal glucose tolerance. After that, we have impaired glucose tolerance, followed by which beta cell failure. So let us explain this chart. In type 2 DM, there is no HLA relationship and autoimmune mechanism. Genetic influence is much more powerful in type 2 DM, and pancreatic beta cell mass is intact in type 2 DM, right? And the alpha cell population is increased. In type 2 DM, it is associated with increased hepatic production of glucose, resistance to the action of insulin, and impaired insulin secretion. So the insulin resistance may be due to any one of the three causes, which are either it may be an abnormal insulin molecule, an excessive amount of circulating antagonist, and other target defects. The last is the most common cause of insulin resistance in type 2 DM, that is the target defects. In type 2 DM, there is deposition of also amyloid in pancreatic islets, that is accompanied by atrophy of islet epithelial cells. Like we have first discussed this chart, now let us understand the mechanism. See, first, the defects in the receptors present in target tissues is generally at the post-receptor level. So, what is happening? There is reduced utilization of glucose by the peripheral tissues, mostly the skeletal muscles, which results in postprandial hyperglycemia, while increased hepatic glucose output produces fasting hyperglycemia. The fasting hyperglycemia is because of the liver, and the postprandial hyperglycemia is basically due to reduced utilization of glucose by the peripheral tissues. First, in the early stages, glucose tolerance remains normal despite insulin resistance. This is due to compensatory increase in insulin secretion by beta cells. So here we can see we have hyperinsulinemia, and followed by which we have compensated insulin resistance and normal glucose tolerance. As insulin resistance and compensatory hyperinsulinemia progresses, the beta cells become unable to sustain the hypersecretion. This results in impaired glucose tolerance and later frank DM. Ultimately, beta cell failure develops. So what are the risk factors for developing type 2 DM? As we all know, overeating, especially when combined with obesity and underactivity, is associated with development of type 2 DM. Aging is a big factor. In females who are genetically predisposed, pregnancy may be associated with development of hyperglycemia. It may or may not disappear following pregnancy. Repeated pregnancies may increase the likelihood of developing permanent diabetes, particularly in obese females. Thank you.